So today we'll be starting our session with art and science of clinical examination in pediatric orthopedics. So the first session will be conducted by Dr. Gaurav Gupta from Delhi about how to go about examination in a child with cerebral palsy. So please go ahead.
Okay. Good morning, everyone. So today we'll be discussing about how to examine a child or how I examine a child with cerebral palsy. Is my screen visible to everyone?
Yes, sir.
Okay. So what all we will be covering is we'll first discuss static examination in short, mainly the practical points. Then we'll discuss the functional classifications, the common ones, and the visual gait analysis. So these three things will help us in making an idea about the difficulties or the stage of cerebral palsy the child is in and what is the probable treatment. So in static physical examination, first we will talk about joint range of motion. Joint range of motion. So what we do is whenever a child with CP comes to us, we try to range the joint. If the child has only spasticity, we are able to range the joint completely in its complete range. But if the child has contracture, we are not able to range the joint. Whatsoever we may try, we should be patient. We should do gradual movement because they have a lot of spasticity. So if you will force, they will become further tight. So you gently, gradually make the child comfortable and gradually try to range the joint. If you are able to do complete range of motion, then the child has only spasticity, which is usually seen in younger kids. And if you're not able to range the joint completely, then the child must have developed some contractures. Then we'll talk about what is spasticity, how we quantify the amount of spasticity. Then we'll talk about lever arms, that is bone alignment, the torsional profile, selective motor control, how to calculate selective motor control, and muscle strength. So joint range of motion I have told, how to check the joint range of motion. Then we assess the muscle tone. So what is muscle tone? It is basically the resistance to passive stretch during resting state. Now it can be normal tone, hypertonic, atonic, hypotonic, dystonic. So usually in CP we see hypertonia, that is they have increased resistance to passive stretch, and usually hypertonia can present either as spasticity or rigidity. So what is spasticity? Spasticity is velocity dependent resistance to passive stretch, whereas rigidity is velocity independent resistance to passive stretch. So this is our MBBS knowledge, but I wanted to revise this thing to everyone. So what is spasticity? Now, type of spasticity, it can be clasp knife type, in which there's increased resistance only in the beginning or at the end of the movement, like the clasp knife. Whereas rigidity can be lead pipe, where there's a continuous resistance throughout the passive range, or it can be cogwheel type, where there's a jerky resistance throughout the passive range. So usually we see spasticity in CP kids, and how we uh, calculate or grade the spasticity is by two scales. One is modified Ashworth scale and another is Tardieu scale. So in modified Ashworth scale, if there is no increase in tone, it's a normal tone, we grade 0. If there is slight increase in tone at the end of the range, we grade it 1. If there is slight increase in range in half of the range, there's increase in tone, then we grade it 1 plus. If it's more marked increase in tone, grade 2, more than half the range. If it is throughout the range, the tone is increased and it's very difficult to range the joint, then it is 3. And if you are not able to uh, do the complete range, then it is 4. 4 is more like a contracture. I personally use Tardieu scale. So here what we do is we try to move the joint. First, we do fast passive motion. So for example, in an ankle, we try to do dorsiflexion first rapidly, and the first catch we feel, we measure the angle from the couch. That is known as R1. After that, we do slow passive motion for the complete range. And the second catch is known as R2. So we measure that angle also from the couch. So R1 and R2. Now we check the difference between R1 and R2. If this is only spasticity, then there would be a gap between R1 and R2. Initial catch can come, let us say if we are dorsiflexing, the child has equinus of like 20 degrees and we do rapid movement, we are able to go plus 10, minus 10, from minus 20 to minus 10. So our R1 is minus 10, and then we slowly maximally do passive motion and we are able to reach plus 10. So from minus 10 to plus 10, so R2 is plus 10, and the difference between both of them is 20. So our R1 minus R2, R2 minus R1 is 20, which tells that it's a dynamic contracture or it has a lot of movement available. Here, if we have dynamic contracture and we have a gap in R1 and R2, we can use physiotherapy and Botox. But if it's a rigid contracture and there is minimal or no gap between R1 and R2, that tells us that it's a static contracture and Botox and physio will not help. We need to do some soft tissue surgery. So that is how these scales help. Now, selective motor control. So it is the ability to perform isolated movements on request with appropriate timing and voluntary control. Usually these kids have poor selective control, and so when we ask them to do one movement, multiple joints move and they are not able to demonstrate one movement. So, and we try to grade it whether there's no ability or partial ability or the child is able to do completely. And how we test this? So we test for both upper limbs and lower limbs. For upper limb, we call it selective control assessment of the for lower limb, we call it scale, selective control assessment of the lower extremity. Here we try to test 5 reciprocal movements of the lower extremity at hip flexion extension, knee flexion extension, ankle dorsiflexion and plantar flexion, subtalar inversion and eversion, and toes flexion and extension. And we score it 0 if the child is not able to, 1 impaired, and 2 normal. Same for upper limb, we check 5 movements: shoulder abduction adduction, elbow flexion extension, forearm pronation supination, wrist flexion extension, and finger grasp and release. And we score it 0 if there's no control and 3 if it is a normal movement. Apart from this, there's one more test which is known as confusion test. So due to poor selective control, these kids are not able to dorsiflex the ankle without moving the hip or knee. If you ask them to do dorsiflexion, they'll move the entire leg. But when the child flexes the hip against resistance, so you avoid them flexing the hip and knee or give some resistance to avoid flexion at the knee and the hip. At that point, they are able to show ankle dorsiflexion. So if you block the movement of other joints, then they are able to show the specific movement. Can we mute the other people? Uh, so apart from that, we check the core strength, checking high kneeling, and we grade it also. If the child is not able to initiate high kneeling, we grade it 0. If the child is able to initiate but is not able to do even 10%, we grade it 1. If he is able to do partially, grade 2. And if he is able to show us complete high kneeling for 30 seconds, we grade it 3. And that tells us that the child has good strength. So these were general points. Now we'll talk about specific joint related examination. So for hip, we do Thomas test where we try to assess the hip flexion contracture. How do we do it? We make the child supine and we flex the opposite limb, flex the hip of the opposite side and the knee also to square the pelvis and to obliterate the lumbar lordosis. After that, we try to gently extend the ipsilateral side, and if the thigh is not touching the couch and if there's a gap, then we try to measure the angle between the couch and the thigh, and that angle tells us the amount of fixed flexion deformity the child has in its hip. Then we check hip adduction. How do we do it? We do it in knee flexion and knee extension. So if the hip adduction is same in knee flexion and knee extension, then it tells that the contracture is mainly at the adductors. But if it is more in knee extension and decreases in knee adduction, knee flexion, it tells us that it is coming from gracilis and medial hamstrings, which are spanning the knee and which gets relaxed when we flex the knee. So adduction increases. But when we extend, they contract and adduction decreases. Then we do Duncan LI test for rectus femoris tightness. So rectus femoris spans the hip and the knee. It causes hip flexion and knee extension. Now, if there's a contracture of the rectus femoris, how do we check it? We make the child prone to extend the hips. We keep the hips extended. If the rectus is contracted, you will not be able to flex the knee. Or if you will force the knee flexion, the hip will automatically go into flexion. So if you flex the knees in prone position, the hips or the buttocks will lift. So that is how you check Duncan's Eli test, the rectus femoris contraction. Then we check femoral anteversion. How we check femoral anteversion? What is femoral anteversion? So it is the angle between the femoral neck axis and the transcondylar axis. Usually these kids have increased femoral anteversion, because of which their internal rotation is much more than their external rotation, and thus they prefer to sit in W or walk with in toeing, and they have difficulty in sitting in out toeing, in cross leg position. How to measure it is by the test named Craig's test. What we do, we make the child prone and we feel the greater trochanter, and we do internal rotation by flexing the knee till the point where greater trochanter becomes maximally prominent or parallel to the couch. At that point, we measure the angle from the vertical with the leg, and that amount of internal rotation tells the total anteversion the child has. From that total anteversion, we subtract the version for that age. Let us say if it's a 12-year child, normal anteversion is roughly 15 degrees, and if the greater trochanter becomes uh, parallel at around 50, so the increased anteversion is 35 degrees. That is how you do Craig's test. Then let us discuss the knee examination. So for knee, we first try to see extensor lag. We make the child sit on a couch with spine straight, and we ask him to sit with the knees at the edge of the couch. Then we ask him to extend the knees with spine remaining straight. So the lag in full extension is calculated by measuring the angle between the uh, horizontal and the leg, and that angle tells the amount of extensor lag. And it is mainly coming from quadriceps weakness and hamstring tightness. So it tells us that apart from quadriceps hamstring release, we might have to do patellar plication or advancement to improve the quadriceps strength. Apart from that, we check fixed knee contracture by trying to do passive knee extension. If the knee is touching the couch, the child has full extension, but if it is not, then he has fixed knee deformity as well. Then we assess popliteal angle, which is very important. How do we do it? So we extend the opposite hip and knee. Then we flex the ipsilateral hip and knee to 90. And then we try to extend the knee. We can do R1 and R2 here. R1 is the first catch on rapid extension of the knee. And R2 is then by doing slowly maximal passive extension. The angle it forms from the vertical, the angle the leg makes is it calculated, and that is how we calculate the popliteal angle and the difference between R1 and R2. So when we keep the other limb extended, we call it unilateral popliteal test, or it tells us the functional hamstring contracture. Then we do bilateral hamstring test, where we flex the opposite hip to square the pelvis, to obliterate the lumbar lordosis and the anterior pelvic tilt, and then we extend the knee. Many times, majority of times, you will see that this angle improves, and this tells us that this entire knee flexion or entire uh, lag in the angle is not only from hamstrings, but it may be coming from weak abdominal muscles or some compensation from the spine as well. So this is known as true hamstring contracture. And the difference between unilateral and bilateral popliteal angle is known as hamstring shift. If this shift is more than 20 degrees, it tells that there is excessive anterior pelvic tilt, which is mainly due to tight hip flexors, weak abdominals, and weak hip extensors. So usually they have poor core muscle strength as well. And even after doing hamstring lengthening, they have very uh, they have difficulty in standing and walking because of poor core. So you can prognosticate these things by checking the unilateral and bilateral popliteal angle. Then about foot and ankle, we see a lot of deformities like equinus, equinovarus, equinovalgus, then hallux valgus, and tibial torsion. So the commonest test we do for ankle is Silver-Shoals test. Here we try to check the tightness in the calf muscles and segregate them. What we do is we flex the hip, we flex the knee, and we dorsiflex the ankle. Now we do it in slight inversion. We check the angle of dorsiflexion. Then we keep the ankle stable and we extend the knee and the hip. If the dorsiflexion decreases, then it tells that it is mainly coming from gastrocnemius. But if we see that the angle remains the same, then it is coming from both gastrocnemius and soleus contraction. And we should always do it with slight inversion at the ankle to lock the subtalar joint. Otherwise, we may fallaciously measure the angle, which is due to midfoot break. We feel that the child is able to dorsiflex, but it is actually coming from the midfoot. So we should always invert the foot slightly, okay? Then we try to check the tibial torsion. For this, we make the child prone and we measure the thigh foot angle. How we measure it? We make a line at the thigh axis, then we drop a bimalleolar axis and a perpendicular to the bimalleolar. The angle between the thigh axis and the bimalleolar axis tells us the thigh foot angle. Usually these kids have tibial out torsion or extorsion. We measure that, and if it is more than 20 degrees, it is considered significant. We can further quantify it or objectify it with CT scan, but mainly the decision is on the basis of clinical assessment. Then we check the foot. For foot, we see hind foot or heel varus and valgus. Heel varus mainly comes from tibialis posterior tightness. Some extent of heel varus can be due to tibialis anterior also, but tibialis anterior mainly contributes to forefoot supination. For hindfoot valgus is mainly contributed by tight peroneal or gastrocnemius. Then we also assess the hallux valgus. So upper limb, due to paucity of time, will not be able to discuss upper limb examination in detail. But what we try to check is selective control, which I have already discussed. Then we try to see contractures at various levels. Like at shoulder, you usually see internal rotation contracture, forearm pronation due to pronator tightness, elbow flexion deformity, wrist flexion deformity, thumb in palm deformity, and finger flexion deformity. We try to assess whether there's spasticity or there is contracture, and depending upon that and selective motor control, we plan our treatment. For spine, we try to see alignment issues like scoliosis, lordosis, kyphoscoliosis. So this was in brief how we do static examination. Then let us discuss about functional classifications of CP. We know there are a lot of classifications, but we mainly will discuss the commonest ones, which is GMFCS and FMS. So GMFCS, or Gross Motor Functional Classification System, is the oldest. It was first described in 1997, and it usually grades kids with CP from 2 to 18 years. It mainly emphasizes on the function of the child in sitting and walking, and it tells us about the functional limitations and the need for assistive devices for that particular child. So there are 5 grades. GMFCS 1, here the child is almost as good as a normal child. He is able to walk independently at home, school, outdoors, community. He can climb stairs without using railings. The only issue is that he has a little limited control or limited, I would say, coordination in running and jumping. So whenever he is doing running and jumping, you can see the difference between a normal child and him. He is not that balanced and normally doing that. Then GMFCS 2, here the child will use a railing while getting up or down the stairs, and is not able to do running and jumping properly. Then grade 3, here the child is using one of the mobility devices. He does not need physical assistance, but he needs a mobility device. And he is obviously using the stairs to get up or get down the stairs. With He is using the railings to get up or get down the stairs, and he needs physical assistance also while stair climbing up or down. GMFCS 4 are further compromised, and they use physical assistance or powered mobility. They may be able to walk for short distances at home, but only with physical assistance and walker or devices. So they need a physical assistance all the time. Then GMFCS 5, they are the most compromised. They are always transported in wheelchairs. They have limited ability to maintain even neck posture, or they have poor head control. So they need a head support also while being transferred or while being carried in the wheelchairs. So now we discuss about functional mobility scale. This was introduced in 2004 by Royal Children's Hospital, and this is used in children between 4 to 18 years. So it mainly takes into account the different assistive devices a child uses in different environments. So here we are basically zooming in, and we are further subclassifying GMFCS 3. What kind of aid the child is using? depending upon how much control and balance he has. It basically rates walking ability at 5, 50, and 500 meters, representing child's mobility at home, school, and community. And the assessment is made on the basis of questions asked from the child or the parent. What questions? How does your child move at short distances in the house? How does your child move in and between classes at the school? And how does your child move for long distances, such as shopping center? So it is graded in 6 grades. Grade 6, here the child is as good as a normal child. He does not need a walking aid or any physical assistance, and he can walk on all surfaces, including uneven grounds and in crowded environment. So it is equivalent to GMFCS 5. Then rating 5, here the child does not use any walking aid or needs uh, any kind of personal assistance, but he requires a rail for stairs. So it is also equivalent to GMFCS 4. Then rating 4 is given when the child is using the child is using sticks for walking. So now we are further defining what walking aid the child is using. So GMFCS 3, where the child is using sticks. Rating 3, where the child is using crutches. So the support is increasing. So here GMFCS 3 with crutches. Then if the child is using walker, then that tells us that the support is increasing from stick to crutches to walker. So still it is GMFCS 3, but the child is using walker. Then rating 1, if the child is not able to walk independently, he is using wheelchair. So it is like GMFCS 2. And if the child is not able to stand or he is crawling, we grade it as C. And if he is not able to complete the distance, we grade it N. So it is like GMFCS 5. So this is how we do FMS grading. It is further giving the details about the assistive devices, or we can say that it is sub-classifying GMFCS 3. So this is the chart for FMS grading. So these are the two common functional assessments we do. Then let us talk about visual gait analysis. So what is visual gait analysis? We try to see the video of the child and we try to assess the kind of walking or do the gait analysis. Now, what are the prerequisites? So the child should have appropriate clothing. That means the legs should be exposed up till the pelvis and above. The child should be exposed till umbilicus. Then appropriate distance, minimum 8-meter distance should be there so that the child can walk back and forth, and appropriate environment. Not much distraction should be there. Advantages: it is cost effective, it is less time consuming, it does not need special training, and it does not need special instrumentation and gait lab. So typically we see two gait patterns, hemiplegic and diplegic. Let us talk about hemiplegic gait. So it is divided into 4 types. Type 1 hemiplegic gait is also known as foot drop. Here the child has a foot drop in the swing phase of the gait cycle. In the stance, the child has a plantigrade foot. Apart from this, other joints can be neutral or slightly flexed. So majorly the issue is in the ankle. So you can see that there is a foot drop in the swing. After that, the feet is plantigrade in the stance phase. Then type 2. So type 2 can be further divided into 2A and 2B. In 2A, there is equinus at the ankle, but knee does not go into hyperextension. It goes into full extension, but not into hyperextension. And 2B, where the knee also goes into hyperextension. So now you can see that there is equinus throughout the gait cycle and the knee goes in extension. Hyperextension. Here the knee is going into hyperextension, so we have graded it as 2B. Then type 3 hemiplegic gait. Here now the proximal joints are also affected, and apart from equinus in the ankle, you see flexion at the knee, which is stiff. There is no change in the range of knee. It is flexed throughout the gait cycle, and the ankle is in equinus. The hip starts flexing, the pelvis is also flexed. So now the proximal joints are involved, and the main cause is hamstrings and quadriceps co-contraction. Then grade 4, type 4 gait. Here what do you see is that along with the sagittal plane deformities, there is a coronal plane involvement also. That means the pelvis is also rotated, the hip is internally rotated and flexed and adducted. So you see that the hip is adducted, flexed and internally rotated, along with knee flexion and equinus at the ankle. So let us talk about the types of equinus which we usually see. These were the four hemiplegic patterns. We'll summarize them shortly. So one is true equinus, where the knee is extended, the pelvis is neutral to slightly flexed, and there is true equinus at the ankle. That means the equinus is due to tightness of the calf muscles. Then there is hidden equinus, where the equinus is mainly due to knee flexion deformity, which is forcing the child to walk on toes. So this is known as apparent equinus, not hidden equinus. It is known as apparent equinus because it is the ankle is neutral, but the equinus is because of excessive knee flexion. Then there is hidden equinus, where to hide the equinus, the child is doing hyperextension at the knee. So these are the types of equinus we see, and we should differentiate between them so that we can focus our treatment on the particular joint. So to summarize, four types of hemiplegic gaits. Type 1 is foot drop gait, where there is equinus in the swing phase. Type 2 is further divided into 2A and 2B. 2A, equinus throughout the gait cycle with knee in normal extension. 2B, true equinus with knee in hyperextension. Type 3, also known as a jump knee gait, where there, along with equinus at the ankle, you see stiff knee or flexion at the knee. And type 4, along with sagittal plane deformities, you see coronal plane issues like hip rotation, flexion and adduction as well. Then let us talk about diplegic gait. So this is also further divided into four types. Type 1 is known as equinus gait. Here, mainly the ankles have equinus. Apart from that, hip, knee are more or less normal. Pelvis can be slightly forward flexed. You can see this child, he is having full range at the knee, but the ankles are in equinus. It is known as equinus gait or type 1 diplegic gait. Then type 2, here along with the ankle equinus, you see knee flexion. There is hip and pelvis flexion also. So now proximal joints are being involved, and due to knee flexion and stiffness in the knee, you see a sorry, I don't know why. Oh, oops. Yeah. So you see that the knees are in flexion, ankles are in equinus, and there's stiffness, not much movement at the knees. So it looks like a jump knee gait. So this is type 2 diplegic gait. Then type 3, now hip flexion is increasing, knee flexion is increasing, and due to collapse of the plantar flexion knee extension couple, the ankles are now going into dorsiflexion. So here you see ankles are neutral, knee and hip flexion increasing, and pelvis is also getting flexed. So now you see ankles are normal. It's more clear on the right side, and knees are flexing further as compared to type 2 diplegic gait. Pelvis is also flexed forward. And finally, you see type 4 or crouch gait, where the plantar flexion knee extension couple has completely collapsed. The ankles are in hyperdorsiflexion. Knee and hip flexion has further increased. It's the most energy inefficient gait, and all efforts in CP are being done to prevent crouch. So here you can see there's significant increase in flexion at the hip and the knee. And due to increased internal rotation, clearance is also an issue. Ankles are in hyperdorsiflexion. So this is a crouch gait or a type 4 diplegic gait. So to summarize, type 1 diplegic gait, also known as true equinus, mainly ankles are in equinus. Type 2 jump knee gait, the knees are also flexed and stiff along with ankle equinus. Type 3, here the ankles are now becoming neutral and the knee and hip flexion is increasing. And type 4, ankles are now in hyperdorsiflexion and hip and knee are in further flexion. It is known as crouch gait. So this was about gait patterns. I want to acknowledge Maulin sir, who has taught me everything about pediatric orthopedics and CP, and a lot of these videos were during my time of fellowship. And I thank you, sir, for giving me this opportunity. So over to Dr. Joyance and Preksha.
Thank you so much, sir. It was a very detailed and nice presentation. Now we have Dr. Joyance with the quiz.
Yeah, so I am sorry, I have to stop here. Yeah.
Good morning, everybody. I hope my screen share, the presentation is visible. And if there are questions, we'll take it up at the end of this. And for this quiz, I want everybody to just pay attention to the videos being shown, and you'll be given 4 options. So kindly put your options in the chat box, and also put the GMFCS score also. And then at the end, then we'll ask one of our faculties or Gaurav sir to describe it for us. So we'll start. I'll just play it once again for those who've missed. And in the interim, we can put our answers in the chat. And also, I request everybody to put the GMFCS score too. Okay. Gaurav sir, would you like to describe the gait and the GMFCS in this chat?
Yeah, so as we can see that the child has increased flexion at the knee and the hip, and ankles are hyperdorsiflexed. So this tells us that the child has type 4 pouch gait. And yeah, and along with that, if we talk about the GMFCS, so he is walking without any walking aid, and is more or less independent walking. This is independent walking, so we grade it GMFCS 2.
Yes. Thank you, sir. So we'll proceed to the next one. Okay, we can share our answers in the chat box. The GMFCS score and which gait pattern is it according to the options A, B, C, D. Okay, we have a couple of answers in this thing. The answers are the option C and GMFCS2. Gaurav sir, would you like to?
Yeah, so we can see that there is hyperextension at the knee, and there is equinus. So this is very rightly type. This is equinus plus recurvatum, or type 2 hemiplegic, we can call it. Here in the lateral
Now,
view.
Gaurav,
Yes, sir.
so this is a question for all the delegates. That why we see the extension more frequently in hemiplegic than diplegic? And diplegic, their tendency to start as a pure equinus, followed by they end up into jump knee and eventually crouch if we see the natural history. So why is it so that the recurvatum or extension of knee is less in diplegic? So anyone can get
Why there is hyperextension at the knee? That is what your question in hemiplegics, right, sir?
yeah, more so in hemiplegic than in diplegic.
Okay, so
You know,
that might
yeah, Gaurav, you can explain that.
that might be to hide the equinus. They have to go into hyperextension of the knee.
Yeah, more than that, you know, it's because in hemiplegic, soleus is also involved. And so when the child walks, the tibia is pulled back and it locks the knee. But in diplegics, usually soleus is spared. In diplegics, we see mostly those muscles which cross two joints are involved. And hence, in diplegics, we see equinus is because of gastrocnemius and soleus is spared. So that's the reason why we see recurvatum in hemiplegics and knee flexion in diplegics where gastro puts the knee, you know, in flexion.
Right, sir. That's a very valid point.
Thank you, sir. We'll move to the next case. So we can put our answers in the chat box, the gait pattern and the GMFCS for this chair. Okay, so okay. So, answers we have come as D and GMFCS2, that is equinus plus jump knee pattern. Gaurav sir, would you like to add anything?
So I feel the child has good range at the knee. He is not doing terminal extension, but still you can see that the knee is moving. It's not a stiff knee, but the ankle is in equinus throughout the gait cycle with some varus also. So I would grade it as uh, true equinus, but definitely it is not jump knee for me because it is not a stiff knee. The knee is moving, although it is limiting terminal extension. So it is somewhere moving towards jump knee, but not jump knee right now.
Okay, we'll move to the next case. So this gait pattern, what does it look like, and the GMFCS, if we can put it up in our chat. Okay, so the answers have come B and GMFCS3. So jump gait plus GMFCS3. And GMFCS, after what age can it be applied? Maulin sir, Gaurav sir, would you like to take and
I'll take
describe
this.
this gait too? Yeah.
So one question by Dr. Puneet is reason for varus in the foot in the last video. So that is that you need to clinically examine, and mostly it is from the tibialis posterior and sometimes from tibialis anterior also. So you need to examine and then you can find out what is the cause of varus. Then in this case, this here you can see a typical stiff knee. In the previous there was movement at the knee, but here you can see on the lateral view that the knee is more or less stiff and the ankles are in equinus. So this is a typical jump knee gait. Since the child is requiring physical assistance, I would not grade it as uh, 3. In 3, the child needs a handheld mobility device, but not physical assistance. So if the child would be able to walk with a walker in this format, I would grade it 3. But if not, and if even after that he needs physical assistance, I would grade it a GMFCS 4 with a jump knee gait. So what's the age after which we can apply GMFCS? I've told in my presentation that after 2 years, between 2 to 18 years, we apply GMFCS. Between 4 to 18, we apply FMS.
Thank you, sir. We'll move to our next case. We can put our answers in the chat box. True equinus is the answer in the chat box. GMFCS 1 because he's fairly independent. Gaurav sir, would you like to add?
Yeah, so I agree. Everybody has answered it well. It is true equinus with it's true equinus and GMFCS 1.
Okay, thank you, sir. We'll move to the next one. Okay, I'll play this once again. So the answers have B, GMFCS 2 and C. Gaurav sir, would you like to take this?
Yeah, so as you can see now, I think you will be able to differentiate between a stiff knee gait or a jump knee gait. Here, there's a slight jump which is involved because of less movement at the knee and along with equinus. So here, as you can see, that there's stiffness, there's a lot of stiffness, and there's not much movement at the knee. Although there is some movement, it is not absolutely stiff, but it is very less from the normal. So it is more or less a jump knee with physical assistance. The child is requiring physical assistance. So if the child will not be able to walk without a walking device, without physical assistance, with a walking device, without a physical assistance, I will grade it 3. But if the child needs physical assistance apart from a walking aid, I'll grade it 4 and jump.
Thank you, sir. Okay. We'll go to the next one. This is a very severe thing, and I think all effort should be made to prevent this, as Gaurav sir said in his talk. Okay, so the GMFCS and the gait pattern. Okay, so the answers have come crouch and GMFCS. Gaurav sir, would you like to describe?
So Tashwin, it should be A, as you rightly said, it's a severe crouch. But GMFCS should be graded as 3 because he is able to walk with a walker without physical assistance. So it is A, crouch with GMFCS 3.
Okay. So, okay, sir, would you like to change the GMFCS scale? Actually, he does not walk at home. He used to crawl only. So he had this very thick calluses on the knee. So he never used the walker. So only for this gait video to analyze, we asked him to do. So if somebody just crawls at home and never walks, so
Yeah,
how would you
so
grade it?
yeah, so if he is not able to walk without aid, then we will call it a or it's very difficult for him to walk, so it is more like 4. You can call it a 4 also.
Okay, thank you, sir. Okay, I think we've come to the end of our quiz.
Okay.
So, thanks, Gaurav and Joyance, for nice presentation. And I hope the young colleagues, they learned the art and science of examination. Each child, when they enter into our consulting room, by looking at them, we would start thinking that which muscles must be involved. And in the era of video gait analysis, still visual gait analysis plays a major role. And as you will advance in your practice, you will find out fine intricacies of clinical exams, which will give you clue about surgical management. But it is wise when you communicate with your colleagues or mentors or co-fellows about if you have a standard definition of gait. And with that, you also need to understand what is the strength of muscles. And the orthopedic world is moving away from soft tissue procedures, and more bony procedures and liver arm surgeries are involved. So we must be very clear about our clinical examination. And then as you advance in your knowledge, you will realize that some of these cases need video gait analysis with further information on kinematics and kinetics. But I would say most of them we can gauge with our clinical examination. So I thank Gaurav for his time and Joyance for preparing a nice brief. Thank you, everyone. Maybe next week we'll meet with another section of this module. Thank you, everyone, for participation. Preksha for moderating.
Thank you, sir.
Thank you, sir.
Thank you.
Thanks. Thank you, Preksha.
Thank you, sir.
Thank you, sir.